Hello, my dear friends, and welcome back to my channel. So, I have an incident. I had a patient who was in 12th standard and he was quite apprehensive about his symptoms. He said that since 6 months he was not able to control his defecation, and he had this loose motions like symptoms. He said that he would pass stool for like 4 to 6 times a day, and he was not able to control or resist them. Then, after 4 months, he experienced constipation. Now, this was in a period of say 6 months and 6 to 8 months. So he was quite disturbed, and it was his crucial years. So he wanted to, get diagnosed and start the treatment right away. So, considering his age and considering his symptoms, I genuinely asked him if he had any stress about his studies or any issues in the life. So he said, yes, I have stress about my studies, and particularly I have noticed that whenever I have the stress or anxiety, these symptoms like they exacerbates. Now, considering his symptoms, his age, he had no comorbidities, I suspected IBS, that is the irritable bowel syndrome in that patient. And when I told this word to him, he was not at all surprised. He said that, yeah, even I feel that it could be IBS. I have researched about it, but none of any gastroenterologist or none of any physician has diagnosed this. But I feel that it is an IBS. So I was quite smiling at him and thinking that he's quite intelligent. So I did refer him to a gastroenterologist for the biopsy, so that we can just rule out celiac and other symptoms of malabsorption, as there were symptoms of loose motions, and he was quite low. He had a low BMI, so I wanted to rule out other malabsorption conditions also. So yes, I would like to talk about IBS today. So irritable bowel syndrome, so this has certain aspects, so we need to remember these aspects, as according to the Rome 4 criteria, it has been said that there is an abdominal pain that is for 6 months. Okay, and it will be more than equal to 1 per week, and 2 out of 3 should be there. It should be associated with defecation. There should be change in consistency of the stools, and there should be change in the frequency. Okay, so now this is something which there will be a abdominal pain, right? So this pain improves with defecation or may worsen with defecation. Okay, so now there will be abdominal pain and there will be a disturbed defecation. That does not mean only loose motions or only constipation. It could be either of them. Okay, so now there would be a lower abdominal pain, right? So this is something which is diffuse. It will be not localizing. It is associated with defecation, which will increase or which will decrease with the defecation, and it is not associated with any menstruation or any food. This is very important because peptic ulcer diseases will be this will be associated with food. Okay, menstruation pain would be certain cramping pain, which is not associated. Okay, so now there would be associated with constipation, or we have a diarrhea. So it could be C, IBS-SD, or it could be a mixed type also that this patient had. Now there would be a blotting sensation and there would be dyspeptic symptoms. Okay, so we need to differentiate that also, right? So now on the examination, there would be a tenderness to that patient. Other than that, we could not find anything other than that. Okay, so there is a Bristol stool scale that will help us to differentiate what it does. So now we have this type 1 to type 7, and this is important because this comes as an MCQ, and especially in the super specialty exams. So now when it is coming as a type 1, there will be separate hard lumps. Okay, it is hard to pass, so this is called a severe constipation, and this comes in IBS-C. When it comes to a type 2, which is also a sausage shape but it is lumpy, that is having a mild constipation. I hope you people can see this, a Bristol stool chart. Okay, so now when it comes to type 3, there is a like a sausage only, but they have cracks on its surface. So and this is considered to be normal. So they ask what is normal, type 3 and type 4. Type 4 is also sausage or snakes, a smooth surface and soft. And when it comes to type 5, it has a soft blobs with the clear cut edges, which is actually lacking fiber. Okay, they are pass easily. When it comes to type 6, it is a fluffy pieces with the raised edges or mushy stool. So there is a mild diarrhea, and this is called as IBS-D. And when it comes to type 7, it is watery diarrhea. It is a severe diarrhea. Okay. Now, what is the epidemiology behind it? This is common in females, okay, and actually it is common in low birth weight people, okay, and this there is a hypothesis, that is hygiene hypothesis, but it is not clear cut. It is not involved in pathophysiology. Now, coming to the impact of the disease. Now, what happens is many of them are been misdiagnosed because of this. So they can undergo hysterectomy, cholecystectomy, appendectomy, and this is really because of the misdiagnosis, because of our fault. So it affects the quality of life. Okay, like this person was very apprehensive. Now, coming to the risk factors. Now, one of the thing is the post-infectious IBS, that is mostly acute gastroenteritis. Mostly it is a protozoal infection, okay, and coexistence psychiatric problem like any stress or anxiety. This is one of them factor. Even we could sometimes experience this before our exams, right? Now, high protein intake is one of the thing, then history of multiple antibiotics intake, and one of the etiology being the inflammatory bowel disease itself, like ulcerative colitis and Crohn's disease, and one of the thing is the celiac disease. That's why when it comes to biopsy, it becomes very important to in all these patients, so that we could differentiate and we can just start with the treatment for celiac disease and IBD. Now, pathophysiology. The first thing is the altered motility. Now, when it comes to the C, that is IBS-C type, there is a segmental contractions in the colon. Okay. Now, there is a non-propagated contractions. There are slow colonic transit time, and there is decrease in the rectal sensitivity. Okay. Now, when it comes to the D type, there is a high amplitude propagated contractions. Okay. There is increase in the gastrocolic reflex. There is increase in the rectal sensitivity. Visceral hypersensitivity. Now, what happens is there will be a gaseous extension, okay, distension. Now, this will increase the colonic stimulation. Because of the colonic stimulation, there is distension. Okay, so now this is the, say, colon, okay, when it is distended, say, so there will be colonic stimulation. Okay, altered neuroanatomy will be because of the neurokinin and CGRP also. The third thing is inflammation post infectious. We have already studied that. Okay, so then whenever there is a 5-hydroxytryptamine, that is a serotonin will be there, which will be released from the enterochromaffin cells. Now, this causes the motility. It stimulates the motility. Okay, so that is also, serotonin is one of the factor. Now, when it comes to the IBS-C, there will be decrease in the release of the 5-hydroxytryptamine. When it is the D type, it will be increase in the 5-hydroxytryptamine. The fifth problem is the FODMAP. Now, this is very important. This topic is very important. Now, there is a fermented oligodimonosaccharides and polyols. Okay, this is FODMAP. Now, which is present in fruits, legumes, and vegetables, that will cause gases production. The sixth thing is the microbiota, which will be like lactobacilli, bacteroids, and enterobacteria, which will increase the IBS. And the bacteria which decrease is the bifidobacterium and faecalibacterium. Okay, so bifidobacterium has come as an MCQ, which is very important, so that it decreases most of the symptoms. Okay, now IBS is actually a diagnosis of exclusion. Okay, the alarming features that we have to rule out IBS is the weight loss. Okay, weight loss will not be there. Chronic diarrhea, loss of appetite, nocturnal symptoms, anemia, vitamin deficiency, arthritis, pyoderma gangrenosum, dermatitis herpetiformis. Okay, so these are the certain things that is we should be suspecting. Other things like celiac disease, or we have IBD. You have to narrow down SIBO, small intestinal bacterial obstruction. So you have to differentiate this. Then we coming to the treatment part. Now, if the patient has this blotting sensation, then it is that patient has constipation. Of course, we have to advise him high fiber diet. We can go with probiotics also, and rifaximin can be administered to this patient. Constipation means we have to go with the increase in the water intake, and we can go with the polyethylene glycol like substances. Then in case of diarrhea, it can be due to lactose intolerance also. When it is pain, we can go with the TCA and SSRI. And FODMAP diet, we have to reduce that. When we are reducing the gluten, it is seen that it decreases the IBS symptoms. Okay, so you would be thinking it will be in case of celiac disease. Yeah, so that's why we have said now it is a diagnosis of exclusion. Then antispasmodic like dicyclomine can be added. Okay, then laxatives for the IBS C type. Fiber diet, that is 10 to 15 gram per day. Psyllium husk can be also used. Polyethylene glycol, which is increases the water content. Then lubiprostone and linaclotide. I don't know why the examiners are really fond of this. Lubiprostone, it is a chlorine analog secretagogue, and we have the linaclotide, which acts as a guanyl cyclic stimulator. So this is very well asked. Okay. Now, opioid receptor agonist, that is the new receptor, targeting the new receptor. We have loperamide and delta kappa new receptor, elexadoline, okay, which is contraindicated in pancreatitis and biliary complications. Okay, so then 5-HT antagonist, that is olesatron, that causes ischemic events. So we have to be aware of this side effect. Antidepressants like SSRI and TCA for the say pain, if there is any pain, so we can try that. Antibiotics like rifaximin can be tried, and 5-HT antagonist and 5-HT4 agonist like procalpride. So this can be also started off. Then mast cell stabilizers like ketotifen is also, I mean, I haven't used, but it has been said that it can be also used. Okay. So remember, there is a theory that the mid cingulate cortex and the prefrontal lobe, this is involved in the IBS. Okay, so this is the theory. So there are multiple theories, like we have already said, post-infectious, anxiety, stress, or because of IBD or antibiotic use. That is one of the pathophysiologies. The mid-cingulate cortex and the prefrontal lobe has been involved in the IBS. Okay, so I hope you have understood this topic. Thank you for watching.